Hey, everyone. Thank you so much for joining us for this fantastic discussion. I'm really excited. We're going to be talking about COVID-19 and nursing homes. The folks at Mathematica have assembled a fantastic panel of experts from across the U.S., which is great. We're going to be going over testing approaches for residents and staff, the role of nursing home staffing, and of course, mitigating the impact of COVID-19 on residents, how nursing homes and state regulators should balance resident health and safety to reduce social isolation, which is becoming such a big problem, and of course, how states can set up their reporting systems to ensure that they have, the real-time data to identify and control the viral hotspots. My name is Jackie Fortier. I am the health reporter for KPCC and LAist. I'm a public radio reporter here in Los Angeles. I cover Southern California. Like a lot of reporters, I started off the pandemic learning about nursing homes. I had already been a health reporter, but I hadn't done a whole lot on nursing homes. And I have really spent the last 8 months reporting on the impact of COVID-19 on nursing homes, nursing home residents, and of course, the people who work in nursing homes. I've been in the New York Times. I've also been on Kaiser Health News and, of course, National Public Radio, which I hope everyone listens to. So we have a fantastic group of panelists. Patricia, if you would just like to start and give us an idea of who you are and what your background is.
Sure. Thanks, Jackie. Hi, everyone. My name is Patricia Rowan. I am a researcher here at Mathematica, and I have been researching issues related to nursing home quality for the last 10 years, and most recently directed a project for the state of Connecticut looking at the impact of COVID-19 in their nursing homes and assisted living facilities in that state. I'm happy to be here.
Beverly Lawbird, if you could give us your background, that would be great.
Beverly, you're muted.
I've been the state long-term care ombudsman for Ohio for 25 years and started my ombudsman career as a local ombudsman in the central Ohio area 32 years ago. And my career has been focused on advocating for excellence in long-term services and support wherever consumers live. Happy to be here today. Thank you.
Dr. Charlene Harrington, who I've actually interviewed before for a story, if you could give us a little background on your area of expertise.
Yes, I'm pleased to be here today. I'm a professor emerita at the University of California, San Francisco, and I'm a nurse sociologist that studied nursing homes for almost 40 years. Almost every aspect of nursing homes and long-term care. So.
Great, thank you. Brian, if you could give us your introduction, please.
Sure, my name is Brian Lee. I'm the Executive Director of Families for Better Care. We're a national watchdog organization located in Austin, Texas. I have a career of nursing home resident advocacy spanning back almost 25 years now. Close to it. I served as state long-term care ombudsman in Florida from 2003 to 2011. I've been the director of Families for Better Care since 2011.
Great, thank you. And our final panelist, Kimberly Smoke, if you could give us your background. Kimberly, I think, we're just going to be listening to you today, right?
That's correct. Thank you. And thank you for allowing me to participate in this panel this afternoon. I am Kim Smoke. I work for the Florida Agency for Healthcare Administration. I am the State Survey Agency Director for the state of Florida. So I oversee all the inspections and all the healthcare facilities in Florida, which naturally does include our nursing homes in the state of Florida. I've been at my role, I've been with the Agency for Healthcare Administration for over 25 years, and I've been in my current role and been a surveyor for 8.5 years before I've moved into more management and now oversight of the State Survey Agency here in Florida. So again, thank you for allowing me to be here today.
Oh, I'm so excited. We have such a good panel. Trish right now is going to give us a little more context on the overall situation. Trish?
Had to get off mute there. All right. Well, good afternoon, and thanks again, everyone, for joining us this afternoon. To set the stage for our discussion, we wanted to begin by giving a general overview of the impact of COVID-19 in nursing homes and other long-term care settings. I know this may be familiar to many of us on the phone, but I think it always helps to ground the conversation. We'll also be discussing some emerging evidence that state and other policymakers can use as they chart out their response. We lost one of our slides. Oh, well, that's okay. Let me just talk through it. So while many of us were celebrating Thanksgiving last week, the country reached a grim milestone of 100,000 lives lost to COVID-19 in long-term care settings. This figure represents both residents and staff who have died in nursing homes, assisted living facilities, and other long-term care settings as defined by the state. This represents nearly 40% of all COVID-related deaths in the country, and cases have been reported in more than 70% of all nursing homes in the U.S. You may recall that some of the earliest COVID-19 outbreaks began in a Washington state nursing home, and the pandemic has continued to really wreak havoc in these settings. This is because older adults in nursing homes and other facilities are at greater risk of complications from COVID-19 than may those be who live in community-based settings. This comes from both a higher prevalence of underlying clinical conditions, the highly transmissible nature of the virus, and the frequent interpersonal interactions that are common in these settings. So what do we know about the reasons that COVID-19 has been so devastating in long-term care? We've compiled here just a few key pieces of emerging evidence that have been replicated in multiple research studies, some in the work we've done here at Mathematica and others in other published articles and papers over the last few months. So first, the strongest predictor of a COVID outbreak in a nursing home is the prevalence of the virus in the surrounding community. This points to the importance of a population-based public health strategy that's focused on keeping community prevalence in the community low and keeping the virus under control. Second, we know that the risk factors in nursing home residents are consistent with those observed in the general population. It's just that nursing home residents are more likely to have some of these risk factors. So for example, older age, weight, underlying clinical conditions, and comorbidities that put all of us at greater risk for COVID-19 are also more prevalent in nursing homes and long-term care settings. We know that higher staffing is associated with fewer cases and deaths. We've also heard in work that Mathematica has done, speaking with nursing home staff, that the pandemic has exacerbated staffing shortages and attrition, and many staffing issues and challenges that related long before COVID was ever really a concern. So this slide presents just a figure of some work that we did for the state of Connecticut. And if you're like me and geography is not your strongest subject, this is a map of the state of Connecticut. And what we did was we shaded each of the individual towns according to their community prevalence of COVID-19. So if the town is shaded darker, that means they had a more severe outbreak and more, higher community prevalence. And then the nursing homes in the state are indicated by these dots on the slide, and the size of the dot represents the outbreak in the nursing home. And what you see here is this almost perfect relationship between towns that are shaded the darkest and have the most community spread, and nursing homes that have the most cases and deaths per licensed bed in those facilities. We also have some emerging evidence related to which residents within nursing homes are at greatest risk. Our work in Connecticut and other research suggests that residents who receive care outside of a nursing home, such as those who leave for off-site dialysis, chemotherapy, or other care, are at a greater risk of exposure. Nursing homes that have a higher proportion of their residents receiving off-site care, therefore, have had more severe outbreaks than do those with fewer residents who receive off-site care. We also know that the impacts of the pandemic go beyond the virus itself. Our work was among the first to use MDS, or minimum data set assessment, resident assessment data, to demonstrate that there have been significant increases in unplanned weight loss and depressive symptoms among nursing home residents, even those who did not contract the virus. This provides evidence to support what many of us have probably heard anecdotally related to the impact on the physical, emotional, and psychosocial well-being of folks living in these settings. And finally, there is some emerging evidence that suggests that nursing homes with higher proportions of Black and Hispanic residents are more likely to report COVID-19 deaths than are those that serve a less diverse resident population. This is an area where more research is desperately needed as we continue to see evidence mount on the virus's disproportionate impact on communities of color. So these next two slides graphically depict some of our findings from the state of Connecticut when we looked at MDS, or resident assessment data. The baseline data point here is March 10th, which was the beginning of the outbreak in Connecticut back in the spring. And basically what you're seeing here is an increase in symptoms of depression among nursing home residents through the end of August. And what you can see is about a 15% increase in symptoms of depression among residents by mid-April, which was the peak of the first wave of the outbreak in that state. This declined slightly in the spring and summer as visitation was opened again. And as more data comes in, it'll be interesting to see what these patterns look like. This is a similar graph that depicts rates of unplanned weight loss, showing that unplanned weight loss nearly doubled after the peak of the outbreak. As many of you know, unplanned weight loss in older adults can be a sign of deteriorating physical condition. And importantly, this pattern was observed both among those who contracted COVID-19 and those who did not, suggesting the pandemic has negative effects that go beyond the virus itself. Now, it's important, as we'll talk about, to point out that, shutting down visitation and other policy measures that took place in the spring were likely critically important to stopping or mitigated the initial spread of the virus. However, this work demonstrates that it comes at a trade-off and a cost on resident well-being. So on that less than happy note, I'll turn it back to you, Jackie, to moderate our panel discussion today.
Thank you. That context is just always key. We're going to start off a little bit with a question that we posed to our panelists before, and then we're going to get into more of our Q&A portion. And just a reminder, if you have a question, we're going to get to our audience questions a little bit later, so you can throw those in the chat box. I'm going to start with you, Bev. I'd like to hear what you think are some of the key lessons learned from this first kind of phase, and what has worked to mitigate COVID-19 in nursing homes, while at the same time maybe limiting the effects of social isolation. And also, if you have thoughts on what the greatest area of improvement you'd like to see as we see these cases surge again across the U.S.
So thanks. I think back to the first couple of nursing homes in my state that had COVID outbreaks, and what worked well was a good partnership with public health and the nursing home and the hospital. So we formed in Ohio strike teams that would get all of the right partners on the phone early on. We would have local health, state health, Medicaid, the facility, key area people in the facility, as well as the management company, the owner of the facility, the hospitals, and so on, and the ombudsman and regulators as well as part of the health department, and just talk through everything that the facility was doing. We even had emergency management on to talk about PPE supplies and how the facility was cohorting and so on. So I think that those partnerships are really important. We see requirements for long-term care facilities to have emergency plans that include infection control. And I think the facilities that have done the best are the ones that had real plans that they actually had practiced and have some experience with the virus. So, and then beyond that, consistent assignment of staff is critically important. And when we talk about balancing the risk of COVID spread with the social isolation of residents, and having good, consistent assignment of staff has been helpful. So residents know the staff caring for them, staff know the residents well. And I will talk about that later too, I think, as we talk more about staffing. But, training on various aspects of the pandemic that were really important from a public agency perspective, being available to facilities as they were dealing with all of the unknowns. And just thinking about going forward, I think we need to talk a lot about establishing a program that is solid around having essential visitors from families to be able to work with residents. Lots of other ideas, but I won't take up all the time right now. Thanks.
Okay. Brian, I'm going to ask you the same question. I mean, lessons learned from these past few months, but I'm interested to hear what you think went or has gone relatively well, maybe something that we learned that we could continue.
Sure. I think that if we could look back over this pandemic to see where the turning point started to happen in nursing homes, where we started to see a decline in infections and deaths, even though it's starting to surge again right now, is the two things. One, the federal government worked to collect data from nursing homes, where infections were held, where the deaths were happening, and then putting together a system that consumers, families, staff of nursing homes could go to as really a data collection repository to get information almost in real time about what was going on in their loved ones' nursing homes, because there was at the time, and still to this day, there are states that information about what's occurring in facilities. In fact, a couple of states even pushed back on the whole idea of releasing that information. States like Texas, Arizona even went to courts. Arizona won their case, Texas lost, and information is being deployed or at least released to the public in Texas now. Arizona, it's not. So the fact that we have a federal system that's collecting information, it helps everybody to get a sense of what's going on in facilities. And I think the second thing is, and I know we'll talk a little bit about this more later, I think the fact that there were testing kits, point of care testing kits, rapid testing kits, devices deployed to the nursing homes really helped. I mean, it was tough on staff to recognize who has COVID, make the distinction between COVID, the flu, cold symptoms. But for the fact that we're able to get the test in the facilities to test not only the staff, but also the residents, is really a game changer. And I think we still have a little bit of more work to go in that area. And hopefully we'll get that buffered up soon.
Yeah, those are excellent points. I'm all for more data. Charlene, if you would like to take a crack at my initial question of what you think maybe some lessons learned at the beginning of unfortunately this pandemic, and I think something like Brian brought up that has really limited the effects of social isolation on residents.
Mm-hmm. Well, in terms of the pandemic, it seems like there are three key factors: staffing, testing, and PPE. And the facilities that have done the best were the ones that were the most prepared in advance and had the best staffing, particularly RN staffing. Facilities that we found in California that had less than 45 minutes of RN staffing were more than twice as likely to have COVID infections. And then we also found in subsequent research that the infection rate is related to the total staffing and to the RN staffing. So those 75% of the facilities did not have adequate RN staffing before the pandemic. And I think the concern is that many of those facilities actually dropped their staffing because the enforcement was dropped and the requirements, there was so little oversight. And so I think that made the situation much worse. And over time in the states, you can see the rate of infections spread rapidly through most of the nursing homes in the state. And then, of course, the testing we can talk about more, but the inadequate testing has been a huge problem, and just not having frequent enough testing for staffing, which if we have many staff that are asymptomatic, and if you don't have weekly or biweekly testing, then that's just a disaster, because by the time you catch it, the infection within the facility, it spreads so widespread throughout the facility. So we can talk more about these things, but go ahead.
Yeah, thank you. I appreciate your initial thoughts. It's such a chicken and the egg problem. You need PPE, you need testing in order to catch cases. I'm going to move on real quick right now. I'd love to hear from Kim in Florida and hear what you think maybe some lessons learned at the initial beginning of the pandemic, and also what you think the greatest area of improvement that we could see now that we're seeing cases surge. I mean, you have so many nursing home facilities in Florida.
We do, and thank you so much. And just, as you mentioned, I'm in Florida, so I can only speak to the Florida perspective. I think lessons learned is really goes along with some of the other comments the panel members mentioned is staffing strategies. Nursing homes really didn't, on the forefront really look at their staffing and understand the complexity in dealing with this kind of, very unknown, early on. We know a lot more now than we did, in March about this virus, which has, I think, helped, at this point, since we do know a lot more, measures we can put in place to try to mitigate, to try to keep it out, although we know cases are increasing in our nursing homes around the country as well. But really, going back to, what we found initially is the staffing strategies. Looking at it from an emergency perspective, emergency preparedness perspective, is to, making sure you have enough staff. The other thing is that we found is, keeping in line with the comment about staff, is nursing homes, and I think this has been in some of the published documents that I've read over time, nursing homes that may have an employee that works 7 to 3 in one nursing home and 3 to 11 in another nursing home in the same county, maybe under different ownership, maybe the same ownership, but we found that too to be an issue early on, and something that nursing homes now have really been trying to pay attention to as it relates to the staffing. And one of the things in Florida that really helped us here is having dedicated facilities, dedicated wings and units and facilities that were really trying to specialize in providing care and services for residents that were positive for COVID-19. Again, I think, not only in Florida but nationwide, we've learned a lot since March. And, none of us like to see cases increasing, whether it's in our state or, nationwide, especially in our nursing home settings. But I think a lot of these ideas that the panel members have talked about today, and a lot of studies that we know will come out of all this as we move forward with our public health emergency, that I think will really help us in the long run really look at nursing home regulatory requirements, in general. So thank you.
Yeah, thank you, Kim. I mean, nursing homes and long-term care facilities have really, come under the spotlight because of the pandemic, which, maybe it's good that we're finally paying attention to these policies around nursing homes, and that people like me are actually being able to dedicate time to reporting on this. It was never really kind of top of mind, unfortunately, until now. Trish, did you have any thoughts on the question that you wanted to share now?
Yeah, so I was actually going to pick up on what Kim referred to as well, which is states that have tried having these dedicated COVID facilities, where folks can go if they're coming out of a hospital, or if they need to be transferred from their home facility for a short amount of time. There's some evidence from Connecticut and Michigan, actually, that these dedicated facilities have improved recovery rates and lower mortality rates than do nursing homes that aren't designated facilities. And so I think sort of for that short-term, really intensive care that's needed for COVID-positive residents, that's actually been, somewhat of a bright and innovative spot. And then I think the greatest area for improvement, the thing that sort of keeps me awake at night from talking with family members and residents, is just the need to maintain communication. As visitors are not allowed in the facility, the staff are trying to help folks do FaceTime calls or video calls, and sometimes if they're low staff, there's not enough people around to help with those things. As the seasons change and folks can't do as many outdoor visits, I think that's really an area going forward that will need a lot of attention to make sure that folks are not becoming more and more isolated.
Yeah, certainly. That's every time I talk to someone who has a family member in a nursing home or is a resident of a nursing home, that is probably the first thing that they bring up. Everyone's touched on a ton of different topics around this. So we're going to jump in and first we're going to talk about testing, because I think that is of paramount importance, if I dare say that, in all these other topic areas. And Charlene, I mean, you mentioned the lack of testing. I mean, most healthcare workers aren't even being tested on a regular basis in hospitals, and certainly not in nursing homes. The current requirement from CMS on COVID testing frequency is scaled back really based on the prevalence of COVID-19 in the surrounding community. And I'm curious as to your thoughts, if you think that that's enough to catch the majority of cases, or how often you think we should have testing of staff in nursing homes.
Well, I think the CMS guidelines are inadequate because it allows for testing once a month for residents that are for areas under 5% positivity rate. And I think that's totally unacceptable. I think we need testing at least weekly, and California has adopted that level of requirement. And then certainly in areas with more than 5%, I would recommend testing twice weekly of staff. And I think that's where we're really falling down. We're not making sure that's happening. So that's why we're continuing to see these outbreaks. We should be able to get them under control by now. So I feel that's the weak link is the requirements are not strong enough.
And Kim, I'm curious, I mean, when you have like so many facilities, I've seen, at least in Southern California, it's been really difficult for a lot of the nursing homes. They don't necessarily want to use the test kits provided, and even if they're given them, they don't always do the testing, and kind of this lack of enforcement that comes along with testing. Maybe even if they're provided the testing kits, they don't do the testing. Has that been your experience?
No, well, I can say, and again, I can only speak for Florida. So,
Right.
In Florida, facilities do either, have the point of care device testing kits, and or they have a contract with an outside lab to come in and do the testing. And, it is based on the county positivity rates in the counties, whether it's, once a month with less than 5% positivity rate, 5 to 10%, once a week, and then more than 10% is the twice a week. And then that is the routine testing. Then there is the requirement for the outbreak testing as well. And other factors that nursing homes should consider is like COVID-19 emergency department visits, proximity of one facility to another county, or even as directed by the state, and even our county Department of Health, or even us as a state survey agency. The requirements are a nursing home can exceed the minimum requirements depending, on maybe what might be going on in their facility. So that while these are I think, somebody uses the terminology, minimum requirements, a nursing home can exceed these testing requirements as well.
How often do nursing homes exceed the testing requirements, though? Do you know?
Well, in Florida, I would have to, gather that type of information. That's not something that I would know off the top of my head, but that is an option. So, nursing home may exceed that minimum testing, again, depending on their individual circumstances and their facilities. And as I outlined, which is in some of the, the other factors that CMS does provide guidance to nursing homes to, which is the emergency department visits, proximity to other counties, and then as directed.
So,
go ahead. One of the problems, Jackie, is I think that CMS requires reporting of positive tests, but they're not really monitoring how many tests are actually being given by a facility. We need real-time data on, are the nursing homes actually following the guidelines? So that's a problem too.
Does any of the other panelists want to jump in on the testing? We've heard it floated the idea of having twice weekly, I'm assuming PCR testing, since it's the most accurate right now. When I've talked to staff at nursing homes, they would love that they need to go, to a county facility if there is one available, to go and get tested on their own time. Seems like staff is willing to be tested.
So,
yeah,
Jackie, can I jump in on this? So, we have been banging this drum. Families for Better Care has since really the beginning of this pandemic on the testing, and it's even though I mentioned in my opening comments that there was a game changer when the feds did send out these rapid test kits and machines to the nursing homes. The problem was, in our opinion, and look, we're not epidemiologists, we're not testing experts, but we can read what the feds are saying, what the data show, and what we know is that tests that the feds sent were the wrong kind of tests. To pick up on what Charlene said, those asymptomatic individuals, antigen-based tests only identify whether or not there's someone who has COVID, who has symptoms, has COVID or not. That's the only thing the antigen-based test does. That's what the Fed sent. We would like to see the molecular rapid tests sent to all of the nursing homes. Really, they need to become their own testing centers for their staff and for the residents. There are machines and there are kits that are readily available that could be deployed really now. And we have been pleading with the federal government since at least April to ask for them to send all of these kind of like molecular rapid testing kits and machines to the facility. So you wouldn't have to worry about sending out a test to a lab, waiting days, maybe even we've heard reports of weeks for results to come back. But these are actual PCR tests that are deliverable results in 10 to 15 minutes. And I think we could also take a page out of looking at how others have dealt with testing outside of the nursing home sector. And, I've continually talked with folks about the National Basketball Association and how they really kind of created this bubble for themselves using saliva-based testing, how they were to quarantine people when they would leave their bubble, and how they would be tested upon return. And it really ensured that there was not a high infection rate with those folks within the bubble. And what we need to do, or what we could create with the right kind of point of care testing at the door, are create these mini bubbles of protection for residents and staff. And I think that people, if they come in, really upon entry, should be tested. I mean, we owe it to the residents who live there that they are going to be able to live in a safe environment. We owe it to the staff who work there that they're going to be working in a safe environment. And the best way we can do that is know if COVID is prevalent or not. I mean, we can wash our hands and we can do social distancing and we can mask up. But if we don't know who has the virus and they are spreading it, that's a problem, because as Charlene said, it spreads like wildfire in these facilities. And when it does, it is absolutely lethal for the people who live there.
I'm interested if either one of our ombuds people would like to jump in on this, then just I've heard from a lot of nursing home administrators that it's, really difficult for them to administer tests, even when they're given these test kits. Has that been, has that also been happening in Ohio? It's so interesting how patchwork all of this is, and that some places have tests and some places are only dreaming of tests. But even when they are given, they're not necessarily being utilized. Bev, I'm curious as to what you have experienced.
Yeah, in Ohio, we know that many of our facilities are using the tests that they were provided by the federal government. And there's a partnership with the state. So the state is continuing to do state-supported testing for facilities that need to test more frequently. Those that are testing less frequently, maybe the once a month, although I can't think of a nursing home in Ohio that's testing only once a month, primarily because so many of them are in orange or red counties, so because of community spread. But I think that it's a hybrid model in Ohio. So some facilities are continuing to do their own sort of in between, and then the state is supporting testing. And there's also an encouragement of facilities, both at the federal level and the state level, to test visitors, especially those visitors who are coming regularly, family members who may be making compassionate care visits, or who have some agreement with the facility to visit frequently because the resident really needs it. And I would like to see them use some of those resources to test visitors. We've had many complaints about facilities requiring family members to bring to the door with them proof of a negative test that they've gotten on their own. And those who are visiting regularly, they would have to be tested weekly on their own. And it's not cheap to do. And some insurance will cover it more than once, some won't. And so, one person told us it would cost me $133 a week to be tested the way the nursing home wants me to be. So I feel like facilities need to use those resources to, again, not just focus on COVID, but to balance the psychosocial needs of those residents. I mean, we saw at the beginning the increase in depressive symptoms and the weight loss and the problems that are happening because of isolation, and we need to deal with that.
I'm curious, Bev, how you know the validity of the testing then that gets reported.
How we know the validity of the testing?
Yeah, do you have quality assurance protocols? How do you know that what they're telling you is correct as far as the testing goes?
Yeah, actually what we've been hearing in Ohio when our governor presents new case data, he's in our state's website talks about sort of a backlog of cases because they're doing tests and then they're rerunning tests and verifying a lot of the data. So that has been kind of a recent change that we have seen. So again, I'm not a scientist, but there are many partnerships through the state formed healthcare zones. So we have a key hospital lead in each of 3 healthcare zones throughout the state. And so they're involved in it, the state epidemiologists and so on. So all of that data is reviewed. It is submitted by our county health departments to the state each week. And then it's put up on the website. We have had some feedback from families and even facilities when data goes up on the website each week saying, wait a minute, that's not our data, or that's not accurate data. And some of it's because of some lag between the testing that's done and the data that gets put up. So that what the county gets from the facility and from the labs and what gets put up on the state website. So a lot of people are looking at it and, contacting the health department and saying, this doesn't make sense. And then they re-look at it. And so what's publicly reported is continuously re-examined.
And Jackie, I would just add, you touched a little bit on this question of testing implementation and administration. We recently conducted a bunch of focus groups with frontline staff in nursing homes, and I was kind of surprised to hear just different levels of trust depending on that testing administration, right? So if there's an external lab vendor that's coming in to conduct the tests, staff seemed sort of most comfortable with that approach. But in other cases, when staff were being asked to either self-administer the nasal swabs or if they were being administered by facility management, there was less trust and sort of less buy-in to the testing regimen. And so I think, especially as states think about their testing guidance for facilities, it's really important to also think about, the nuts and bolts of operations. How are these tests being administered, and how can that be done in a way that ensures, accurate, complete, and valid data?
Yeah, certainly. It's interesting to see how much it varies, not only from state to state, but even from facility to facility. Keeping kind of in the same vein, I definitely want to talk about vaccine distribution, which is, I think, going to look similar to testing in that, it's going to require healthcare workers potentially going into nursing homes in order to give these vaccines. I've got a big thoughts on this. If there's a policymaker watching right now, watching our conversation, who is planning for a COVID vaccine, distribution as it relates to long-term care in nursing homes, what would you like to say to them? Who would like to talk first?
Well, I would like to say that we know from research which nursing homes are high risk. And the high-risk nursing homes are those that have, in terms of residents, more male residents, more residents 85 and over, and more residents that are Black and Latino. So I would really like to see the vaccine rollouts to target the high-risk nursing homes. Of course, there are other factors that are high risk, but in particular, those three factors should be considered in the vaccine rollout.
Yeah, that's an excellent point. We've certainly seen a disproportionate effect on communities of color, of course, and then also in nursing homes. I did a story back in May with the New York Times where we looked at the data on how it's impacted nursing home residents in the Los Angeles area. And it was just very, very clear. Latino folks especially have a higher mortality rate. And that has unfortunately continued. My big broad question for any other panelists. Kim, do you have any thoughts on vaccine distribution plans in Florida?
Well, again, only speaking about Florida, and it really is. I think it goes to our previous panel members' comments is really looking at those, high-risk nursing homes, in states. Also, I think that, you talked about, like policymakers, I'm the regulators. So whatever policymakers put into place and rules and regulations that me and my staff have to enforce. But I do think it's important that policymakers get input from advocates such as ourselves, as yourselves on these panels, and also providers and residents in long-term care facilities. I think that our residents and our family members, have the largest voice, and really policymakers should be listening to them about, vaccines, and the rollout of the vaccine plans, and how it goes, from state to state, and that, and again, whatever policymakers put in place, that's what we have to enforce from a regulatory perspective.
Yeah, I agree with that, Kim, and I'm glad to hear you say that policymakers need to hear from residents, critically important. And I would say also, let's not forget about assisted living. There are so many, assisted living is not federally regulated, and so they haven't gotten the same attention as nursing homes have from the federal government. But we have to keep in mind that many assisted living residents look very much like nursing home residents. They are just as at risk as some nursing home residents. So I think it's important for us to really look at those facilities as well and the population there, and not just assume that nursing home residents are more at risk than some assisted living residents might be.
Yeah, Jackie, just to jump. Oh, sorry, go ahead.
No, go ahead.
I was just going to say, just to maybe play a little bit of a devil's advocate here. I'm absolutely certain that we all want to be vaccinated as soon as we possibly can, so we can get beyond this crisis. But I'm a little concerned about a rush to vaccinate in these facilities. I know that they are, they have been petri dishes for this pandemic to kill people. But there's still a lot we don't know about the vaccines, how they're going to affect the elderly in these facilities. I have a little bit of pause for concern, because I don't want to see that our nation's nursing homes and assisted living facilities become really the control group for our nation, to see how this is going to affect the rest of us. Unfortunately, this pandemic it makes it look at times that the elderly have become really the disposable generation, because it's been kind of, in some regards, sluggish responses and helping the nursing homes, helping the residents, helping the staff, by policymakers, by elected officials to ensure their safety. And I just think that we need to be diligent in our response to make sure that our parents and grandparents aren't the disposable generation, that there's enough care given to them, and attention given to them, and caution when it comes to vaccinating them. And I'm also concerned about if people are given the option to not be vaccinated as residents, is all of a sudden, Bev as the state ombudsman and all the other ombudsmen across the country, and Kim, all of a sudden, are they going to start being inundated with these involuntary discharge notices because residents have refused to be vaccinated? And then all of a sudden we begin to demonize these folks that refuse. So I think there's a lot of rights issues that we have to still kind of unpack and put together, and then also think about how it's really going to affect our families who are living there.
Yeah, those are excellent points, and we have multiple vaccines in obviously, production as well, as far as and also trying to get federal approval. But that's an interesting point too, in that there's also a lot of medically fragile people who won't be able to get a vaccine, even if they want one, or choose not to. It's going to be, I don't know if any of our ombudsmen want to comment on that now, but moving forward, I don't know if there's any sort of regulatory way that people could be discharged for not getting a vaccine or for refusing it?
Well, certainly that would be a violation of regulations. If they were to try to do that, unfortunately, the inappropriate discharge is a huge problem nationally, and there's been a lack of real enforcement of the rules on inappropriate discharge.
Yes, discharge is our top complaint every year. It was only recently eclipsed by visitation complaints just in the last few months, but discharge nationwide is continuing to be a problem. CMS has been pretty strong on discharge related to a number of situations where we've had people who wanted to leave to go to a wedding or leave for the day to visit family, and facilities threatening to discharge them if they left or not welcome them back when they returned at the end of the day. And CMS has been clear to say that that is not a valid reason for discharge of a resident. So I would hope that CMS would be very clear and strong in preventing discharge if someone decided they did not want the vaccine. We don't discharge people if they decline the flu vaccine or a pneumonia vaccine, the other things that some are part of some quality measures. But I think that it's important for people to have choice, an informed choice.
This is Kim Smoke, and I would just like to add to that, regulatory-wise, that is definitely not one of the reasons to transfer or discharge a resident under the federal requirements. And just to point out something else, CMS takes very seriously and acts very strongly when there is an inappropriate discharge of a resident. In Florida, we do investigate those complaints and to encourage, ombudsmen and even, family members to report those to your state survey agency for investigation, because we really do take very seriously an inappropriate discharge, especially during this time. And we all have had cases that we have seen, in newspaper clippings and, received information from our, complainants as well. In Florida for inappropriate discharges, which we do investigate. And like I said, CMS does take it very seriously. We have to report when we cite those specific deficiencies to CMS for them to take any additional actions as they deem necessary. So I would hope, as somebody who would have to deploy staff to investigate those, that nursing homes not go in that direction and discharge individual residents inappropriately if they do not wish to take the vaccine. And I think made a valid point too when you said, an informed choice and informed decision. I think the onus is going to be on the nursing homes to ensure that they are adequately educating the residents and family members about the vaccine and just with anything else, like the flu vaccine is, as we previously discussed. So just wanted to state that, from a regulatory perspective, especially here in Florida, and what we are held accountable to from CMS as far as investigations of inappropriate discharge.
I'm going to stick with you. Go ahead.
I think generally speaking, we don't give residents enough credit and remember that they've lived very long lives making lots of decisions for themselves, and we need to continue to empower them to make those choices.
Yeah, if there's something that I've learned over doing a lot of interviews with nursing home residents, it's that they are still people. I think that that's something that a lot of, unfortunately, policymakers as well tend to forget, and they have opinions about how they want to be treated, and they have had really long lives, like you pointed out. We had an interesting question from the audience that I just kind of want to bring up to the forefront before we move on real quick. Someone asked, how have you found worked best in keeping resident councils and families informed and involved and providing input through the ups and downs of responding to COVID-19? When I've done interviews with family members, LA County and the state of California has done a decent job putting data up, but family members didn't even know that data existed on the website. And I have had multiple instances where I'm interviewing a family member and I say, well, hey, there's been 50 deaths in the nursing home that your mom lives in, and they had no idea until I told them. So I've seen a really big disconnect between something being thrown up on a website and a family member who maybe they don't have access to the internet, or they're not aware that the website exists, even having that information. So I'm curious as to what you guys think has worked well in keeping resident councils and families informed. Brian, do you have any thoughts on that?
Yeah, absolutely. Thanks, Jackie. I think I'm going to go back to something you said right at the beginning of the webinar, and that is going back to the media. And I have to say that, you know, my years of doing this, I've never seen such a sustained investigative journalism and reporting on nursing home issues for such a prolonged period of time. I mean, and I think that's been a huge help for families because we've had numerous phone calls from folks where they've contacted us and said, you know, I didn't even know that there was an outbreak in my mom's home until I read it in the paper this morning. No one's told me. The nursing home has not. This is the first I've learned of it. So I think that the fact that there has been this scrutiny of the sector for this long is going to pay well, of course, short-term dividends, but I think long-term dividends too. It's going to help policymakers to kind of formulate what's going to work in the future. I think that the fact that we have that reporting happening is helping them immensely because, you know, I did pull down some data today from CMS's website where it talks about communicating with residents and families, and there's new citations that they have come up with, and one related to the COVID infections, and one is about communicating residents, the representatives, families. And there has been some enforcement around that. And, you know, I know that Kim could probably talk a little bit about this in Florida, but as a whole, there's been some enforcement. You know, there's not been substantial enforcement. And this has been a real concern because we still hear about this from people, even though that there's new guidance, there's new regulations, there are fines associated for not reporting, but the enforcement has not been tough enough on some of the nursing homes. In fact, cumulatively, I see that there have been 55 resulting fines in the nation related to these incidents. So there's CMS and the survey agencies are aware of this as a problem. I think the families would like to see maybe the state survey agencies, the regulators, to kind of, you know, help wake up the nursing homes to the fact that hey, you're supposed to be contacting families. You know, what can you do to help?
Kim, did you have any thoughts on that?
Yeah, as Brian mentioned, there is a regulatory requirement for reporting that facilities must report to residents and to family members. That regulatory requirement came out, I believe, in May, and that is something that we do look at when we do focused infection control surveys. It's also something that we look at when we do our recertification surveys, what some states, like us in Florida, have restarted doing as well. Also, I do encourage, again, ombudsmen and family members that might be listening to this, share that information, as Brian mentioned, with your state survey agency. If we don't know that that residents aren't being told, or families, then there's nothing we can do about it. We do need to know that. We are not, as regulators, we are not in every nursing home every single day. But if something is brought to our attention, we do review it and can take action as deemed necessary.
And just so I'm clear, oh, I'm sorry. Go ahead. Go ahead, Beth.
In Ohio, facilities are required to send whatever family notification they're doing for families and residents. They are supposed to send to the survey agency. And then the state's public health order also gives ombudsman access to all of that as well. So we've actually encouraged facilities to be proactive and give the information to their local ombudsman. So when families call us, then we can say, well, this is what I received from the facility. Does it match what you got? And then, we can check in with the facility if we're not receiving things. So we can say, hey, what's going on? Have you been notifying people? So, and we get family lists, call family members, call residents to check on them and ask those questions.
And has that been working for you?
Generally so, yes. Occasionally we do hear from families who say, I don't know anything that's going on. Often what we learn in those situations is that maybe the facility had called a different family member. And so the communication hasn't been happening. So we've also been trying to educate families to say, pick one of you, and make sure that you're all communicating together. So whoever gets the information from the facility is communicating with the rest of the family. And we've reminded homes also, you're very focused on communicating outside of your building to family members. Don't forget to tell your residents what's happening and what your plans are. For the Coronavirus Commission on Safety and Quality in Nursing Homes that I was a member of, our recommendations was about frequent communication. So because CMS has this blanket waiver that someone can be transferred without the normal notice if they need to change rooms and so on related to COVID, we worked on a recommendation that make sure the residents know when they're being tested. So if this test comes back positive, this is our cohorting plan in the facility. So this is what might happen if you do test positive. So people are continuously updated and know what the facility's plans are.
Yeah, that sounds great.
Important for...
Go ahead, Trish.
Sorry. I was just going to say, I think it's important for facilities to try to be as creative as possible in their communication, right? So I've interviewed family members and facilities that are doing, creative things like Facebook Live sessions or Zoom meetings that folks can pop into, and sort of just creating more and more opportunities for family members to plug in because they don't really have the opportunity anymore to just, drop by the nurse's station and ask questions while they're in the building because they can't visit as much. So I think that's just really important recognizing that folks are short on staff, I don't think is a really great excuse. I think it's important to make sure that there is, strong and continuous communication, and also that families know who they can contact if they have questions, right? So I've heard about family members like stalking facility staff in the parking lot or things like that just because they can't get anyone to answer the phone. And so it's just critically important that, family members and others are scared if they read about an outbreak in the paper or something like that. They need to know who they can go to get accurate and real-time information.
Yeah, and I think we need to remember too that there's a lot of people who are interested in what's going on, and one of our panelists brought up, I think it was Bev, who was talking about making sure to keep nursing home residents updated on what's happening. I've talked to a lot of nursing home residents who say, my roommate just disappeared. I don't know where they went. I don't know what's happening day to day. I would like to transition a little bit and talk about staffing, because that has been just such a huge issue. We are months into this pandemic. The people who have been working, in long-term care and in nursing homes have been doing it for months and months and months. We already had high staffing turnover before COVID-19. Charlene, you are the expert certainly in this area. I'd really like to hear more about your research on how, nursing home staffing has been tied with fewer COVID-19 cases when you have more staffing. You mentioned earlier 45 minutes. Was that the patient time for one patient specifically?
The 45 minutes of RN time is the average for all of the residents within a facility. So we know from our research that that's an absolute minimum time. And then if residents are sicker, they should have more RN time. And we also know from research that 4.1 hours per resident per day is a minimum. And so we see that the high-risk nursing homes are the ones that have below this. So we would like to see the states put out, we'd like to see states have higher minimum staffing standards. But during the pandemic, I think the states could put out guidances to the nursing homes, advising them that the research is showing that the RN time is critical, because the RNs are the only ones really trained in infection control in identifying infections and identifying other problems like, strokes or heart problems or whatever. And they're the ones who are supposed to be supervising the licensed vocational nurses and the nursing assistants. And they're the ones who help set up the infection control plans. So not having enough RN time is just really the most serious thing you could do. And what? And then we also know, as you said, the average turnover rates are about 50%. And so we see that from the research that especially on weekends and nights, there are frequently the nursing homes are violating the minimum rules because they don't have RNs or licensed staff there. And these turnover rates are definitely associated with higher infection rates. So staffing, it needs to be addressed on an urgent basis. And we're seeing that nursing homes that have better pay rates, of course, they have lower turnover rates. They have a more stable staff. And then the staff are not working at so many facilities if they have reasonable pay rates. So the nursing homes that have been offering hazard pay, I think have found that that's a very effective way. But there's also a new study that just came out by Leading Age, and it's advocating for a 15% wage increase for all nursing assistants. And the estimates are that would stabilize the entire workforce, just a 15% raise. So I think policymakers and nursing homes really need to realize they have to invest in their staff and get the staffing up. They just can't continue to do what they've been doing, so many of them. And most of the ones that are the violators are the for-profit nursing homes, because by cutting corners on the staffing, they can increase their profits. So
I think it's telling that the coronavirus. I think it's telling that the Coronavirus Commission made 27 recommendations and 9 of them were related to workforce. It's really a huge issue. One of our recommendations was to, and I should say that I endorsed some of those with reservations because I didn't think they went far enough. So RN coverage, there's a recommendation that there be an RN 24 hours, 7 days a week when there is coronavirus in the facility. You can't wait until you have a positive case of COVID in your building. You need to have an RN there all the time to start, detect and do those assessments that only RNs can do. So I think that that's really critical. So I think some of those workforce recommendations didn't go far enough. Absolutely. We need more staff. And, we have seen, the use of PPE slows down the care process. Complaints about medications being late because the nurse who's delivering medications has to don and doff PPE in between residents and in between wings, longer just to administer medications. And so that has, major health impacts on residents. And so they really, even facilities that are adequately staffed under normal times, they need to increase staff. We had one facility that laid off activities personnel because they weren't doing group activities. Well, why not use those people to go to have one-on-one interaction with residents who are lonely and stuck in their room? So some facilities kind of went the wrong direction and they needed to increase their personnel. And it doesn't always have to be, I mean, obviously we need aides and nurses, but we need people to answer the phone, expert on several residents and be connected to those residents' family members, to be the communicators about what's going on. So there are many roles for people to help residents in long-term care. And I think facilities need to be more creative, and we do need higher stand-ups. Absolutely.
Yeah, that's an excellent point, especially about having more people who have training to be in nursing homes, like you were saying, the event staff. Brian, I'm curious what you would like to see as far as staffing goes. I mean, it's easy to say, yeah, we need more staff at these nursing homes, but there's not a lot of people lining up necessarily to do these jobs right now. But from an advocate's perspective, what would you like to see?
Well, I agree with Charlene. Well, in fact, I agree with this whole panel. So I think that there should be hazard pay for folks, should be increased wages for folks on the front lines, really across the spectrum for all positions and facilities at this time. And look, the nursing homes have been paid a gobs of money through this whole pandemic. I'm talking like truckloads of money. We've given them at least $21 billion, at least $21 billion. And we need to see more of that money being diverted to staffing and to make sure that we're taking care of those people who are taking care of our loved ones. They're putting their lives on the line to keep our loved ones safe. So we want to make sure that they're getting paid as they should, that they have enough folks working shoulder to shoulder with them to keep them safe. And look, staffing is something that is a solution that I think we can all agree with. I think that all the advocates can. I think the regulators can. I think the industry even recognizes the fact that staffing is critically important to the nursing home marketplace. So this is why I have to say, good on New Jersey. Governor Phil Murphy signed a staffing law during this pandemic, starting in 2021. They're going to have all of these things that we're talking about. They're building it into their legislation. And this is why I know it can get done. And we've been calling for this for years to try to get more staffing. Ombudsmen have long before I've even became aware of nursing home issues, calling for more staffing. And so this is why it's surprising to me that we have a federal legislation that's been proposed to try to fix the nursing home universe called the Nursing Home Reform Modernization Act. And this is supposed to be the response to the pandemic. And when I look through this bill, and it's a good bill, I think it's fine. But when I look through it, there's nothing about staffing, nothing. So we need to have bills, legislations filed, and there has been in the past, but we need to actually really get serious about passing a staffing law that's going to keep through this pandemic and beyond in nursing homes. I mean, let's just do it. Look, when Florida passed the staffing bill back in 2001, it was really the gold standard. And Florida was complaining, the nursing homes were, about lawsuits. The care was atrocious. Florida had some of the worst staffing levels in the country. They passed that bill. And as soon as that happens, the staffing goes up, the care gets better, the lawsuits for nursing homes go down. It's a win-win for everybody.
Well, and then on the other hand, if we pass more legislation and more regulations, we have to have enforcement, right? So that's always the back end of it. Tricia, I'm curious if there's anything regarding like staffing shortages or any solutions that we've seen during the pandemic. I mean, in LA alone, I've seen them, bring in National Guard troops in order to plug staffing holes. They're talking about doing it again. I mean, it's just gotten to critical levels in a lot of areas in order to fulfill this need. But I mean, do you have any takeaways that other people could implement maybe for finding staffing right now?
Well, that's a great question. I mean, one of the things that I think we saw as a good solution earlier in the spring and summer when the pandemic was really hot in certain regions of the country is that, folks were able to move people around. They used temp agencies. Large nursing home chains could move people from one spot to another when they had staffing shortages. My concern right now is the whole country's on fire. Everywhere's a hot spot, right? And so where are we going to find licensed and competent folks to come in and fill some of those shortages. So I think that's really important to think about going forward, and it points to the need for increased pay and more respect and things like that for this workforce. I think some of the innovative solutions that states have tried are to, for example, in Connecticut, they have sort of a nurse aid and training program that allowed folks who are interested in working in nursing homes to take some online courses. And then they work one-on-one with a nursing aide. They're not providing hands-on resident care, but as you suggested, Bev, earlier, they are doing, they're helping folks with FaceTime calls or calls with their family, or they're helping serve meals and things like that. So it just sort of adds some extra bodies in the building to help fill the role that, I think you'll hear from a lot of folks that, family members, when they go to visit, they're sort of an informal workforce, right? They do their loved one's laundry, or they bring a meal or something like that. And with visitation not happening, all of that is sort of going out the window. And so having these staff members who maybe aren't, licensed to provide resident care, but can help with other necessary tasks, I think is a really innovative solution that states and facilities should be considering.
Yeah, absolutely. I agree with that. In Ohio, when a facility is having a staffing problem, they can reach out to a bridge team that was created when the state started doing testing months ago. And so there are 3 levels of support: the staffing agencies that the facility might not have taken advantage of. I think that's more beneficial for assisted living facilities, maybe, who aren't used to using staffing agencies. The second level of support is a licensee bank. So a request goes out to a bank of licensees that were identified when the pandemic began as, people who were available, nurses and so on, who might be available to help. It was originally developed for hospital surge. And then, so that's helpful in many cases, and then the facility just hires people from that licensee bank. And then the third level is National Guards. So we have, right now, I think we only have 1 nursing home with National Guard support for a few days, but we've had several at a time where National Guard goes in and sends nurses and medics being the nurse aides, to provide care for a certain period of time. So again, what's so important there is the partnership and the work with the emergency management agency, because they're managing that process with the National Guard. And so we put in missions, and National Guard responds. And so that whole system of partnership is really important.
We've got about 15 minutes left until the end of our, it's flying by, right? I want to take some questions from the audience. So if you guys have any questions, please put them over in the side chat here. Crystal, I want to look at her question because I think it's a really interesting one. She's asking, what are best practices that you've seen with collaborating with the community to keep COVID out of nursing homes, since high community prevalence is an indicator of surges of COVID in the nursing homes? And she's exactly right. We see more cases of COVID-19 in nursing homes after there's high community prevalence. This also, I think, comes back to the idea that, Kim, you talked about earlier, of having dedicated wings and facilities that are positive. And Trish, you mentioned that seems to be somewhat effective. I mean, it's so fast. As soon as you get 1 case in a nursing home, you're almost guaranteed to get more. Kim, can you talk about what you've seen in Florida that's been effective?
Well, yeah, thank you. One of the things early on that we did here in the state of Florida under Governor DeSantis's leadership, working with our agency, is setting up some dedicated COVID wings and nursing homes. We had 23 facilities throughout the state of Florida. About 5 of those were fully dedicated nursing homes, and the remaining had, wings, units, or sections in which they dedicated as COVID positive. That was a best practice. that we utilized here in Florida. Were they some bumps along the road? Absolutely. And I think with anything, again, early on, we were still learning a lot and still are learning a lot about COVID-19 and that virus. So that is one of the best practices that we felt really helped us here in Florida. Try to mitigate it as much as possible is, really having some facilities that were really dedicated to that. Really, had a lot of support from our emergency management offices and our state Department of Emergency Management, our county Department of Health. We went in as regulators, and I'll just let you know, even though they were, dedicated wings and units and facilities, if they were areas of concern, if we received complaints from families or even residents or other, outside sources, we still were the regulatory agency and we still investigated those. But we did find that was one of the things that kind of, helped us early on with the pandemic is having those dedicated facilities. So thank you for asking that.
Yeah, and I'd also like to bring up too, like cohorting of workers as well is another thing that we've seen other facilities do that seems to have worked relatively well. Charlene, were you going to jump in?
Yes, I was going to say that we've had some very serious problems in California with the cohorting of facilities because the state never really set criteria for which facilities that facilities would have to meet in order to become a special COVID-19 facility. So we saw that 22 facilities, I think, were set up in Los Angeles, and almost most of them were below average in terms of both their staffing and their quality scores. Only a few even were average. And I really believe that was a terrible mistake. And nationally, you have to have standards. You can't just, once a facility gets a bunch of COVID residents, they shouldn't be allowed to become a COVID-only facility. So I think we've learned that from the pandemic so far, what not to do.
I think there's an attraction.
Yeah,
sorry, Jack, I was going to say, I think there's an attraction for some operators to become COVID facilities. And the attraction was that some states were offering reimbursement bumps. They got more pay for having more COVID residents. And Texas, I know that they were giving a reimbursement increase. I know that Florida was giving a reimbursement increase. And I know that, the Center for Medicare and Medicaid Services has really kind of greenlit that because there's additional cost to I'm sure, with PPEs and testing, et cetera. But, in Texas, Florida, it was really led by the policymakers. In Texas, it was not. It was an initiative by the facilities. And you started to see them to almost give an appearance that they were going out to kind of get people in their facilities so they could get an additional reimbursement increase. It was a financial incentive for them to do so. And I think that Charlene is exactly right. There has to be standardized criteria for these facilities when cohorting is happening. I just haven't seen it. I mean, Kim could speak to this a little bit more because I don't read all the fine print of everything, but I didn't see a lot of it in Florida and how they were determining, publicly they were doing that. It's happened in Texas. So, it's been, it sounds good on the surface because it could be focused resources on a specialized problem, but how that's really playing out is it's kind of head scratching.
Kim, is there anything that you wanted to add?
Well, like I said, early on, this is something that we identified, and as Brian pointed out, we made that decision internally, to go in that direction. We just felt that, that was something that we needed to do, again, it's lessons learned here is that, when this hit, nobody knew. When we knew better, we do better. And I think that's the point of some of the conversation we're having today, is, sharing, things that we saw that maybe didn't work, things that we saw that worked that maybe weren't 100%, but things we could do better. And that's what we found, with the dedicated centers. And you're right, some of the things that was help from that help facilities from a reimbursement standpoint is, they had to staff up. You had to have, that dedicated staff. You had to provide that extra training, that extra oversight to those staff, in addition to the PPE needs. Again, so much was not known about this virus early on, and still we're learning. I just want to keep emphasizing that, we're still learning about it. But, those were some of the things, that we looked at from a, reimbursement side too, is getting things in place for these facilities to do this. And I just want to refer back to the Centers for, CDC. There is very clear guidance on CDC's webpage about, setting up a dedicated wing and unit, having your dedicated staff, your separate entrances, separate break rooms. So that's what we relied back on too, is, our requirements refer us back to, CDC, and, CDC changes those things. And so that's what we would, make sure facilities were adhering to. So thank you for the follow-up questions on that. We worked very hard to establish that here in Florida. Again, it was something that, our agency leadership pushed, and Governor Ron DeSantis was really behind that, initiative as well, and wanting to get that done for our residents in Florida.
We only have a few minutes left, so I want to bring this up. I think everyone would really like to hear if you guys have any ideas on what facilities can do to help the mental health of residents right now. Obviously facilitating, conversations with their family members among staff. However, if you don't have very much staff, that's difficult to do. If you have any, closing thoughts on what if a facility administrator is watching right now, or a policymaker, in order to help alleviate that mental burden, that would be great. Brian, do we want to start with you?
Sure. I was thinking to tell an administrator what we could do to help them right now. I'm going to go back to what I was saying before. I think that nursing homes are still desperate for equipment. I think that we do hear from nursing home administrators that PPEs are still in really short supply in some areas. Some places they're stockpiling, and the information about the equipment is sketchy sometimes. So, whatever resources that we can get to them, the testing, the PPEs, to help them to care for their employees would be beneficial, to help alleviate the mental anguish for the residents. I think we've taken a huge leap in that direction by just unlocking the doors, allowing families to be able to return was a gigantic policy shift. And developing criteria so that we can get families back in safely. I still like to see testing at the door for folks, but just for that alone is helping the residents, and it's helping them not only from a isolation standpoint, but also from just the care perspective. So we've made some progress, but let's keep pushing forward.
Bev, do you have any closing thoughts that you'd like to add?
I think visitation is very important. I think facilities need to give their staff permission to sit down and have a conversation with residents, and not every time an employee walks into a resident room have it be focused on providing care. I mean, obviously they have to provide care, but give them permission to take time. And that's going to require them to bring in more staff, to give them the time and ability to do that, and recognize that this virus is having on these residents, and let them go outside. We've had so many residents tell us, I just want to go outside. We've had some residents joke that they're going to take up smoking because the smokers get to go outside. And if they don't smoke, they don't get to. So fresh air is so important. Put on a winter coat and go outside.
Yeah, that's an excellent point.
Big difference is what residents tell us.
Yeah.
Charlene, is there anything else that you'd like to add?
Well, I'd really like to see nursing homes get the family members, the essential family members back in. They don't have much incentive to do that. So I think the states need to really force the nursing homes to let visitors back, make sure they have PPE and testing. And that's the best cure for loneliness, is to have the visitors and the family members there.
Got away from my mute button there. Well, it looks like we're at time right now. I really want to thank everybody for sharing your perspectives on all of this. Mathematica is going to have some follow-ups after the webinar. It's been a great conversation. Thank you to all of our panelists. And we look forward to having another panel soon on this topic, because I'm sure there will be a lot more to say. Thank you again, guys.
Thank you.
Thank you, Jackie.